So sometimes we'll experience a trauma and we say, I never want to feel that way again. Maybe avoidance, downers, like you were saying, shutting down, totally avoiding. And then we have that other end of the spectrum where there's some traumatic reenactment. There is, kind of being drawn back to those same places and events.
Hi everyone, thanks for tuning in and watching my video, whether it's at the start of the release or after my channel's blown up in a couple of months. Nice to have you here. The following is a conversation with a guy called Thomas. He's from the USA, works in Indiana. He's both an addiction therapist as well as a sufferer of OCD himself. And we talk about his treatment with patients with addiction, his advice, his own experience with OCD, and the process he went through in healing. And I think it's a fantastic conversation that I think you'll really enjoy. Whether you're seeing this channel now when it's first been released or in a couple of months, I'd really appreciate a like and a subscribe and a share, because I'm trying to get this message out to as many people as possible. We're producing content where people are being honest and vulnerable about their experiences with childhood trauma, addictions, abuse, their mental health struggles, just so that we can help as many people as possible. Whether it's in a week, a month, or a year, I know my channel will be a success simply because of the content I'm producing. There's nothing else like it on YouTube where people have honest and open conversations like this with their face shown and are free to express themselves and be vulnerable and be seen. All I'm trying to do is help as many people as I can heal from their trauma and prevent other people going through what you and I will have been through. So any help you can give me will be greatly appreciated, and know that you're doing it not for me, but for other people, so that other people don't suffer like we did. So thank you for all the help you give me. It's enough for me rambling. You want to hear from Thomas? Here's the interview. See you soon.
Starting off with like my day job, what I do, I run an intensive outpatient program that focuses on chemical dependency and trauma related disorders. So that's sort of my day to day. So a lot of addiction work. And as soon as I got into addiction work, I knew immediately that if I don't become competent treating trauma, I'm going to be very bad at this job. I think especially at this level of care, right, which is like one step below hospitalization. I don't know if there's what the equivalent would be outside of the United States, but it's pretty high level of care. It's 9 hours a week that I spend with people typically. And it's almost unanimous that if someone ends up in this level of care, that there is a very significant trauma history too. So I was like, okay, well, I got to figure out as much about this stuff as possible. And that sort of kicked off that journey. It's not where I expected to be or what I even wanted my specialization to be, but it's sort of where I ended up.
But that's the thing, they're also intertwined: trauma, addiction, mental health, essentially lessons that we've learned from our environment. So to some degree, you have to be trained in all 3, 4, 5 different aspects, however many there are, so that you can provide care to an individual, because everyone is different. We try and throw people into boxes and say, oh, you've got ADHD, so you've got this, or you've got bipolar, so you've got this. But we both know it's not really the case.
Yeah, absolutely. It's the conversation I have with people a lot, kind of like a chicken and the egg thing with addiction, which is like, did I become addicted because of all of these past experiences, or did I start using drugs and accumulate all of this trauma, and that sort of kind of kept fueling it? And it's messy, right? People are messy. There's not like a sort of one size fits all approach. But what I think everybody agrees on is that these past experiences absolutely are kind of fueling our trajectory, right, to a certain degree. The analogy I use with my patients when I'm working with them, it's kind of the difference when we're talking about substance use. That is, like, if you give someone who's experienced a bunch of trauma a substance of some kind, it's like giving someone who's been walking through the desert for 3 days with no water, a glass of water, versus someone who, has never, or someone who's like fully hydrated, right? So it just kind of grabs you, right? Because of those, it fills that need, I guess, that's sort of left in our brain.
Yeah, I was talking to someone else today. Funny enough, another bald guy from America. I feel like I've met my twins today in an interview. He was a correctional officer for a period, and then also went inside, but struggled with addiction to alcohol. And we were discussing where that came from. Personally, my addictions, at one point, I struggled with marijuana, and it was the ability to help me escape from reality and escape from the pain that I was feeling inside. I don't know if I think you can relate to that, or you have some understanding of that with your patients, right?
Absolutely, yeah. And you bring up marijuana, and there's a frustration I have with people not taking like that addiction seriously, right? As we sort of, that's really what I see too. Every substance sort of has different challenges in terms of treatment, but one is my people who have cannabis use disorder have a really hard time. Like they're basically pushed out of rooms, right, in the AA/NA space, and it's really, really frustrating. But you're right, like Gabor Mate, I don't know if you're familiar with him. I think most
Very
people who are
familiar.
sort of, yeah, in that trauma space, he says, not why the addiction, why the pain, which I think is a really, succinct way to kind of put it, right? We're covering something up there in a good way to figure out some of your goals too, is like, what is this drug doing for you? And how can we get more of that in our life in a way that's not holding us back, right?
Super interesting. I mean, now I'm thinking about myself. Like I said, I used it as a way to escape and a way to, I don't know, hide from my unhappiness. But in reality, what I needed to do was face my unhappiness and accept it and move through it. The biggest driver for me in quitting was to do the podcast, because it's really what I'm passionate about, because I don't want people to hurt like I hurt. And I listen a lot to Jordan Peterson. He talks about doing something meaningful with your life, not something necessarily fun or something that brings you happiness, but something that brings you fulfillment. And that was, I think, what was missing from my life, a sense of what am I actually doing with my life? What am I actually achieving personally? I don't know about you. Have you ever struggled with addiction? We haven't talked about that.
So I have not struggled with addiction. My trajectory into the addiction space was, like I said, mostly accidental. So I did have a period. Well, I guess I'll just kind of like walk us through that trajectory, because substance use is involved in it a little bit. But
The floor is yours, man. You talk away.
well, yeah, thank you. So I started. I had very early onset OCD, so I started showing symptoms around like 6, 7 years old. It was a scrupulosity at that point, right? Which is sort of a religious fixation. I was at a Catholic school at the time, so it wasn't hard to.
Oh, they're fun, aren't you? Aren't they? They do a number on your brain for a bit.
They did, and my OCD really latched onto that, right? So, constant rituals and praying, avoiding the color red, the number 6, all kinds of fun stuff. It was a bit weird because, my parents, they were concerned. They thought it was like, schizophrenia, because, when you're a kid and you're having intrusive thoughts, it feels like voices, right? Something outside of yourself. So that's kind of the way it presented. But they brought me to a child psychologist, and they were like, he, overactive imagination is sort of what they came away with. I don't quite understand why it happened, but it sort of went away for quite a while. And when I was 16, it got really severe again, right? So if we were kind of measuring, on that scale, I was all the way on the other end of it, and that over 4 hours a day spent obsessing, washing my hands, 4 showers a day, all of that stuff. So I was totally debilitated by it. And it went that, I didn't end up getting, I didn't want any treatment for it, first of all, because I was like, what is talking to some dude, gonna do to get me to stop compulsively washing my hands or obsessing about this stuff? Luckily, I had parents that saw those symptoms and they had some leverage, right? I wanted to go to college, and they were like, you aren't going to or we're not going to help you go to college if you don't also seek out treatment concurrently with it. So reluctantly, I went, and I got very lucky because I ended up with good therapists, which, there's a lot of bad ones out there. And OCD is particularly specific to treat. So therapists tend to it's very bad at treating it. And luckily, I found a clinic, that's all they did. And we did exposure therapy, right, for about 2 years. Because by that point, my OCD had shifted from a religious fixation to a sort of contamination OCD. So fears of, feeling dirty all the time, washing my hands, again, all of that stuff. So we did something really fun. I don't know how familiar you are with exposure and response prevention therapy, but
Get out of my head, because I was just writing it down so I could ask you about it. Tell us.
yes, absolutely. So you start by creating a hierarchy of your fears, right? Your obsessions and compulsions. You start with the least severe and work your way up to the most, all right? One thing about this, because I do like talking about it, because in hindsight, it's very funny, but I don't want to freak people out who are thinking about exposure therapy, because when I jumped to the end, I was doing some pretty extreme stuff. They will ease you into it. They're not going to overwhelm you right away, and you will surprise yourself. But it started, right, touching my shoes, whatever. And even then, at at that time was very stressful. So you touch your shoes and eat without washing your hands, whatever. And we worked our way up. And I'll never forget like the last, 2 exposures. And I still haven't figured this out. I was smart enough, so I was 18 or 19 around this time. And I was smart enough to know that they weren't giving me a vial of real blood, but they did a very good job because it was in this little medical vial. It smelled like blood. And that exposure was, rubbing on my hands, not washing my hands and eating. I still haven't figured out how they quite did that. And I have worked with other exposure therapists and stuff, and I haven't found their blood recipe. But it was funny because I was in college and I just, I had roommates. And so I had this like jar of blood in the refrigerator, and they didn't know me very well. So I'm just this fucking weird guy, eating,
washing his hands with blood and then eating.
Yeah. So I'm sure that was very bizarre. And I've always been like a pretty open person. So, I'll talk a little bit about it, but it was bizarre. And then the very last one they had me do was throw some paper clips in a toilet at their, clinic, reach into the toilet and pull the paper clips out. And you're not allowed to wash your hands, mind you. So carrying those paper clips around with me, taking them out, like constantly, rubbing all over myself. And after that, they were like, okay, you're fixed. See you later. I was no longer afraid of germs. And I got tremendous relief from that, man. I know sort of at the end of it, and I think with a lot of successful treatment, there's almost like a grief that happens because you're like, I'm so much more comfortable now. And I spent so many years just totally overwhelmed, like mourning, to the time I went to bed, my mind was on something unpleasant, right? All of that energy, it kind of like ruined that first relationship, all of those sort of like times that you're going through during this like pivotal time in my development was sort of colored with some of the OCD stuff. But yeah, no, so I got a ton of relief, which was fantastic. So to anyone out there who is sort of on the fence, it's worth the work to sort of put into that. But at that point,
that goes for all mental health healing though, right? You've got to put in the effort and the work to make a difference to yourself. You can't just sit back and hope it will fix. You have to take the lead.
Absolutely. Yeah, there's no easy way. There's no way around it, right? The only way is through it. One thing, have you ever seen The Shawshank Redemption?
Oh yeah, of course. Great film, yeah. Obviously.
One of the best, right? And, his tunnel through all the sewage and, everything to sort of get out of the end of prison. I kind of equate that to trauma and exposure work, right? With OCD. Any type of therapy that works, even if it's not therapy, right? Even if we're trying to work on this stuff on our own, it's going to involve some type of exposure, right? You're going to have to get uncomfortable to a degree. If our brain's not uncomfortable, we're not adjusting to anything, right? And so we that's something that we have to do.
Unfortunately, with mental health, you come into a space where you stay within your patterns because you're uncomfortable. So for me, I'd be smoking marijuana because I was uncomfortable with, say, my loneliness or my failure, my lack of achieving things. And you have to confront that uncomfortable feeling to heal, I think.
Absolutely. Yeah. I mean, at the end of the day, when we talk about addiction, it's a really extreme form of avoidance, right? And if you want to feel better, you have to sort of find a way to break that cycle, and whatever that is. By no means am I one of these people that think, therapy is the only way to do it, right? As a therapist, I think sometimes we sort of overcorrect and we're like, everybody needs to be in therapy all the time. I think it will speed things up for a lot of people, right? I wish I did it earlier. But also we can do this stuff ourselves and try to find our own ways out and use those supports. And that's obviously valid too. But like you said, the amount of, pain and how long we sort of stay in those spaces trying to avoid discomfort, it's ridiculous because it doesn't work. We're still dealing with this stuff every day. When I'm talking to people, we're talking about doing exposure work with trauma. I always tell them, I'm like, look, you're dealing with this stuff every day anyway, right? We're just doing it in a controlled way to kind of help, dissipate some of that.
Sure. I forgot what I was going to say. I'm really sorry.
No, you're fine.
Screw it. We'll rewind. Before we started recording, we came to the agreement that most mental health, trauma, disorders, depression, whatever, are learned majority from your environment. I'm curious to know or try and understand where you think your struggles with OCD and cleanliness came from. Are there specific incidents that you remember from your childhood that you think have influenced you?
Yeah, it's really that's kind of the question, right? So we have this ACE score, right, which is your adverse childhood event. Easy 10 questions. I'm sure you've been familiar with it. I would score like a 1 on that, right? My trauma history is very limited, and I do think psychologically, that I had the wiring for that. And I think when you expose a child to the concept of eternal damnation and you have that sort of anxious circuitry and you kind of latch onto that, I think that's a huge problem, right? I mean, I think that's sort of where it started in searching for relief, right? That snowball started.
So for you, it sounds like maybe it came from school and that threat of an eternal hell and the Catholic Christianity vibe. Is that fair?
Well, yeah, that was definitely the first domino that got flicked over, right? Where it was like, oh shit, because yeah, I mean what could you? I mean, it's literally the worst thing imaginable, right?
Yeah.
Per everyone at my, everyone in charge of me at school.
Is there a specific memory that stands out for you, or from? I'm assuming we're talking school rather than
Mhm.
your home life. Is there a
Yeah,
single? Is there a specific memory that stands out, or a douchebag teacher that still haunts your brain?
there is, and it's interesting because my parents weren't even particularly religious, right? They were just like, oh, Catholic school, smaller classroom, that'll be cool. But I remember they were breaking down an analogy, and they were like, every time commit a sin, you get closer to, this hand's the devil, this hand's, you or whatever. And so every time you commit a sin, you get closer and closer, and then you're like fucking high fiving the devil, I guess. And that like metaphor was very effective for, a 6-year-old, 7-year-old, and that really stuck into my brain and sort of created a lot of anxiety early on.
I'm sorry to hear that. I had something similar. I mean, I went to a Catholic school until I was maybe 8, I guess, but I don't remember that fear of God and fear of the devil ever being pressed on me so hard. I think there's a slight cultural difference there, maybe between America and the UK. I'm guessing a little bit. I think religion. We've seen extremes of religion, or extremes of religion in America that we probably don't see as much back in the UK. I think.
That is my understanding, right? America is particularly intense about it, right? And I know that I know our rates of like atheism are a lot lower than other developed nations.
Are they? I didn't know that.
Yeah, I believe so. Don't quote me on that, but yeah, no, I know America's a particularly religious country, right? A lot of Christians, and that's going down. But we do see a lot of like, or at least, and I think you also have to grade this on a curve because I'm growing up in Kentucky, right? It's not like if we were in California, you might have a Catholic school that's a lot more liberal and less intense about that. So I am biased in that regard, but they were pretty intense.
Kentucky being a red state as well. Yeah, it's not New York or California or Delaware, like you said. I'm curious about your siblings, if you're happy to talk about it, because off air we were discussing, or they came up, and you said that all three of you had your own personality disorder or your struggles with a diagnosis of mental health. Do you know, or are you willing to share what their struggles are or were?
Absolutely, yeah, yeah. And so my brother's is also OCD, and and what was kind of unusual about that, because I had an extremely early onset, his was a lot later. Like he didn't start, having severe symptoms until like his 20s, and his, got pretty severe, pretty similar in themes, I think, as mine. But when it happened, I connected him to the same place I got treatment, and he responded slower to it. And I think he had like, I think with like the later onset, maybe it doesn't, he had a little issues with the response, but he's doing a lot better now. But he also, yeah, his was also OCD. My sister, so she was a medical social worker at a children's hospital, right? Always kind of, we were all a little bit more anxious, I think, than the average bear. But when she started, seeing, what you see as a medical social worker in a children's hospital, we talk about trauma. Those sort of reactions started coming up, and luckily, she was in the healthcare field. She's a therapist like I am, and got it under control. But yeah, it was a little bit different where hers was kind of strictly trauma that she saw. Where my brother and I do think, it's kind of more of a hereditary thing where we just had that circuitry, and when our brain found the right thing to sort of like fuse to, it was off to the races. I do think about OCD, it sort of works along different lines as addiction, but the snowball effect is very similar. So, as you wash your hands to get a little bit of relief, if a little's good, a lot's better. So it's similar to addiction in that type of thinking, right? And how out of control it can get. And trauma sort of works that way, with avoidance, I think, right? But so we were all very anxious kids, and I think we just kind of won the lottery on that too, because we had very supportive parents, very caring parents, but our biology was shitty. And then it was activated by our environment, right? Like we were kind of talking about earlier.
That was my next question, to pivot away from your school life and focus more on home. My struggles mostly came from my home life, from the abusive upbringing or an abusive environment I was in. Can you relate to that, or were your parents, I don't know, how is your relationship with your parents now?
Oh, it's great. So yeah, my mom's one of my mom and dad we're all very close. And as we get older, it kind of turned into more of like, now we're just kind of friends. I look forward to visiting them. So like I said, we don't fit the mold in that way, right? Where all of us have great relationships. I talk to my sister and my brother almost every day. I visit my parents at least once a month. They're about an hour and a half away.
That's nice, man.
Yeah. So I was, so lucky. I can't imagine. I think about this a lot where, I wonder what would have happened had I had that predisposition, right, to mental illness and didn't have that support, right? Didn't have parents that cared, or even, being in America, right? If I didn't have parents that could help me access that treatment, right? That was fucking expensive, man. Like, and insurance.
Yeah, I bet. I mean, the American healthcare system is completely different to the one that I've seen in the UK. So yeah, I'm glad you had that support. Carry on. Sorry.
Yeah, so I'm grateful about that. Constantly, we all got really lucky in that regard, and it shows in our outcomes, right? Where we were all able to like get it under control and manage it relatively quickly, which I think was good. But it kind of does work against a little bit. There's kind of two schools. I shouldn't even say two schools of thought, right? We kind of entered this trauma informed period where we're all really dialed into it, and I think that's amazing. And one of the really great kind of books, have you read Body Keeps the Score?
Oh yeah, fantastic book. Basil Van der Kolk, I think it is. I'll put a link in the description for anyone who hasn't read it. It's a fantastic book. Focused on trauma.
Yeah, and it's interesting. That thing's been on the bestseller list since like 2014, and it's a pretty dense book. Like it's written for clinicians, but people just grabbed onto it, right? Because it really speaks to something in people, and he really gets into sort of how complicated that can look. OCD is a little different in that there is a really big hereditary component, right? And we kind of look at identical twin studies to see that. So between fraternal twins, which my brother and I are fraternal twins, you'll see that like 20% crossover, right? And then
forgive me, they're not where you're not identical.
Yes, when you're not identical. So my brother and I genetically are the same as like my sister and I would be, right? Just because we just happen to be born at the same time. But when you're an identical twin, you share 100% of the genes, right?
Sure.
So one way to look at heritability is to say, okay, well, what percentage of fraternal twins are likely to develop this, and then what percentage of identical twins? And the identical twins is, like 80%, right? So like substantially higher. So that genetic component is just really huge right there. Now, trauma can look a lot like OCD, right? Where, if I experience I think even COVID could be a good example. Like if I, had a family member that got put on a ventilator and died horribly, then suddenly I'm afraid of a virus, and you're taking all those precautions, it probably would have looked a lot like I looked, right? As I was like washing my hands all the time and, checking for symptoms and stuff. The difference is that at the core of that is an intrusive memory that sort of has to be dealt with. And a lot of times with OCD, there isn't quite that thing that you can focus on, right? You have to focus more generally on the themes and kind of work, both respond well to exposure to a degree, right? But you're kind of targeting different things, if that makes sense. So yeah, that was a little bit of a tangent, but
that's the point of these conversations. I'm enjoying learning. I know very little about OCD. One thing I haven't brought up with you yet, I always had this thing I used to do as a child, and sometimes I still catch myself doing it now. If you have a rectangular table, I wouldn't like to walk in line of where the corner is pointing. So I'd always try and step over it. And I don't know, that was my little tidbit of OCD that I have. I find it uncomfortable to do that, to the point now where I will deliberately do it to, unfuck my brain to make sure that I'm not, I don't know, susceptible or letting my weirdness or my brain beat me. As a counselor, what does that say to you? Does that suggest anything to you about me? I'm curious.
Well, one way that I like to think about this stuff is I'm not measuring whether or not a symptom is there. I'm measuring the degree in which it interrupts your life. Okay. So, we think about OCD and there's this huge spectrum, right, of symptoms. I think a lot of people have a couple hiccups, right, in terms of like the example that you just gave with the table or, maybe liking things a certain way. And it stays like subclinical, right, for most people. So, it wouldn't tell me much until, it starts affecting your relationships or your job or your goals or, how much of your time is sort of being used. Because no matter what symptom we look at, we all have like some, these like quirks and things that aren't perfect about ourselves. And one of the issues that I have with our healthcare system is that we sort of pathologize totally normal behavior, right? Or totally normal responses to bad situations. And that is one thing that I want us to kind of move away from and just look at like, is this holding me back in some way?
Editing a video today, I'm trying to think what the participant said. Trauma is a perfectly normal reaction to a very abnormal event. Mm-hmm. That really resonated with me. I really like that. Like you've done whatever you can in the moment to rationalize with your young brain this terrible, awful thing that's happened to you. And maybe it manifests, for me, manifesting in not wanting to stand in the corner line of a table. I've no idea where that came from. I've never thought about this. I'm trying to think why I might do that. I can only assume that it was a way to distract myself in the moment from things going on. Like it was a little game maybe I could play with myself. I've really no idea. Couldn't tell you.
Yeah, and I think like a lot of these like sort of traits that we have, a lot of times we aren't going to get the answer. We aren't going to be able to sort of draw a direct line between it because, when I talk to these psychiatrists or people on my treatment team who are so knowledgeable and I respect them so much, a lot of times, you'll ask them these questions. Why does this happen? How does this medication work? And a lot of times the answer is we don't really know. We're just guessing. So, yeah.
It's a work in progress, I guess.
Well, yeah, we got to figure it out. I mean, if you think about these kind of scope of medical science, right? Psychology is in its infancy. You think about, Freud was kind of the pioneer that got that started, or, one of them. And, he's operating, early 1900s. And so, yeah, 100 years, that's nothing, right? So we're still just babies,
No, I've said this to other people as well, that I think the psychology field does not understand mental health. We're still trying to fit people round pegs into square holes, and we're trying to fit someone with a series of symptoms or behaviors, diagnoses that completely overlap. Just because you've got this, and this doesn't mean you have bipolar. Just because you have this, and this doesn't mean you have ADHD. You have a set of environmentally influenced personality traits, and it's not something you're born with, it's something you learned, and I think we need to do a lot of work on it. It really frustrates me, the use of pills and medication to treat disorders. I don't think I don't think they've really ever helped me, and that it isn't to knock them for anyone who takes them. For God's sake, keep doing what you're told to do, and if it works for you, it works for you. But antidepressants, for example, I never found to work for me. What I found to work for me is understanding why I am the way I am, what's happened to me, taking control of my own psychology and saying kinder things to myself than the negative, nasty things I would say. I'm curious, talking about medication, if there are medications used with OCD. I'm guessing there aren't so many. Is that right?
So, the way that they tend to medicate OCD is through selective serotonin reuptake inhibitors. The difference with so the difference with OCD that you would see, we are just using it for generalized anxiety disorder or depression, is that the dose that they use is much higher.
In depression, the dose is higher.
No, I'm sorry. The dose for obsessive compulsive disorder is a lot higher. And you
Okay.
do see, a reduction of symptoms with people pretty like consistently, right? I mean, however, once you come off the medication, you kind of go back to square one, right? You decompensate. And then when you're taking the higher doses of SSRIs, you tend to have some more side effects. I think it can be a useful tool, but, so for me, just so what happened to me, I kept going to the doctor because I had all these like health concerns, and he knew it was anxiety. So he was like, "Here's an SSRI." Put me on like 10 milligrams of Lexapro, and I had nothing but terrible side effects. It didn't touch my anxiety, and when I went and got treatment at a clinic, the first thing they did was take me off of it. Thank God, because it was pretty miserable. And then through the behavioral therapy, I put into remission, right? I wouldn't even meet criteria for OCD anymore. And trauma's like sort of a similar way, right? They have medications that can like kind of treat some of the symptoms that come up, but you're going to have a much more reliably positive response from some type of exposure therapy. I'm pretty cautious to poo-poo medication altogether. I think it's a great tool. I think if you're depressed, about 50% of people are going to have a good response to it, and I think we should use every tool that we have, if I'm being honest, right? And some people are not willing to.
100%.
Yeah. So some people are not willing to spend 2 hours a week sticking their hand in toilets, right? Or, going through their trauma or talking to someone. So if they're willing to take a medication and get some relief to that, like, cool. In terms of best practices and what I would want to see first, because there's so much baggage with medication, give some of this other stuff a shot, maybe, and see what helps. We have some really exciting stuff kind of coming up. At my level of care, the intensive outpatient level of care, when symptoms are that severe, I really like both, to be honest. I want to be hitting it kind of on every level where, if they're open to it, we don't, push anyone to it, but medication assisted treatment, especially with addiction, dramatically improves our outcomes, right? And with people with severe, depression, anxiety, stuff like that, do both, right? Is kind of like, what I kind of like to see with people. But everyone's different, and we really have to, respect and work with what our patients want, right? That autonomy and kind of go from there. I do think, because in my case, a general practitioner, someone who doesn't specialize in psychiatry, threw one medication at me and never followed up, and I had no response at all whatsoever. That's like not the way I want to see mental health care at all, right? I want psychiatrists and people who focus on psych, because it is such a challenging right. And that's always my whenever someone's dealing with a mental health issue, I'm like, find the specialists, right? Don't go to a
Well,
generalist, and find someone who deals with that every day, right?
no, you wouldn't go to a pediatrician if you needed surgery. You'd go to the person who knows what they're doing. It does take time. You have to go and find a specialist, and you have to go and find the right specialist who understands you. There are some crappy therapists out there. I've certainly seen my share of them who, I don't know, for whatever reason, they aren't as good as they could be. I think I'm always a little bit wary personally of a therapist who doesn't have any of their own trauma. I think there are some therapists out there who have said, oh, psychology seems quite fun. So they go to university to study psychology, and then they become a therapist, and they'd say, well, what does the book tell me about OCD? Okay, I've got to do this. Whereas I'd rather go and see someone like yourself who does understand it and who has experienced it and can tell you the nuances of why exposure therapy and putting your hand down a toilet and carrying these paper clips around might be good for you. I must put your contact information videos in the video description, so if anyone comes up against it and likes your vibe, that they can get in touch with you. I'd much rather see a specialist who understands narcissistic abuse for myself than just any old therapist. But it does take time, and you've got to find the right person.
Yeah, absolutely. And sometimes, you can have a really good therapist that just isn't a good fit for you. Yeah, or like you said, even a really good specialist. And if you're not vibing and you're not, I always tell people to be really picky with the providers in your life, right? I mean, if you don't like your therapist, switch therapists. Like whether it's a personality thing or whatever, we're not a good fit for everyone, and that's cool. And a good therapist is not going to, it never feels awesome when someone's like, hey, I'm going in a different direction. But I would much rather someone do that than like 6 months down the road, we're not getting anywhere because they're not comfortable with me or doesn't want to open up or whatever. Because, and being a trauma therapist, that happens all the time that people are like, hey, I'm a lot more comfortable talking to a woman, or hey, you remind me of, my, stepdad or something, right? And I'm just not going to be able to open up to you. I'm like, okay, yeah, let's find someone that will,
I decided lately I didn't want to see a female therapist anymore because most of my trauma comes from my mother. And I realized seeing my last therapist, that was often triggered by some of the things she would say. I actually ended up binning her off because she complained about me missing sessions to go to my dad's funeral. And I just got furious at her. Yeah, I got furious at her for that because she made it all about herself. And I just saw too much of my mother's behavior in her, and I realized, fuck this, I'm out. So I've been looking to find a male therapist ever since. I had a point that I wanted to say, and again, it's lost me.
But we were talking about being picky and how like having those
Oh,
preferences. Yeah, listen to that.
forgive me. I just remembered what I wanted to say.
Good.
I think that I worry that a lot of people with mental health issues and disorders, whatever, because they've come from a background that is, say, abnormal, if there is such thing as normal, or perhaps abusive or neglectful, sometimes you don't have the necessary self-esteem to stand up for yourself and say, hey, this isn't working for me. And you sort of just trundle along with what you've been given. I wonder how many people in America have been to a general practitioner who's ended up throwing Prozac at them or the other drug that you mentioned and thought, oh, okay, well, I've got this one now. Like, I'm just going to take it. And then after 3 months, it's still not working. They think, oh, well, it must be me. So I'm just going to keep taking it. And unfortunately, that takes time to develop that, not willpower, but the self-love for yourself, to believe in yourself and think, no, fuck this. This isn't working. I need to find something different that works for me. And that isn't easy for everyone. It does take a bit of time, I think.
Yeah, I mean, we're essentially asking a traumatized person to stand up to an authority figure in a way, right? And yeah, is everyone going to be ready to do that? No, but yeah, and it is really unfortunate. You asked like how many people there are that like stick with a therapist that isn't working, and it's a lot, right? I'll get people to me that they've been doing talk therapy for years and years and years, and they've never been introduced to some of the most basic interventions, whether it's for trauma or OCD or depression. Like they haven't even done the meat and potato stuff, and they're sitting here told they're treatment resistant. It's like like that's stupid, right? That's a shitty therapist or whatever the practitioner is, because yeah, there's a quality control issue for sure. So yeah, like that's the takeaway that I would really want is like if you've been doing talk therapy for a long time and you're not getting anywhere, well, find someone who does a different type of therapy. And another thing is if you're seeing a therapist and you have no idea what their theoretical orientation is or how they approach problems, like you're just kind of coming in freak of the week stuff, like you're not getting good therapy, man. That sucks. And move on, right?
Yeah, for sure. But also the shame and the stigma around mental health also creates that barrier. And that's the whole point of the podcast, is we can come and talk about these things. I think maybe OCD is slightly different. If you say OCD is hereditary, I didn't know that, but I'm more than willing to believe you. All right, let's pivot again and talk about addiction, because that's something that we've not necessarily covered so much. We've spoken more about OCD. But forgive me, you said that you see a lot of outpatients in addiction, but people who are really heavily addicted, and particularly about substance abuse. Is there a particular substance that you're focusing on? Are we talking about cocaine? Are we talking about opioids, marijuana, alcohol? Where are you at? What are you looking at?
I work with everything. In Southern Indiana, the biggest problems we have are meth, alcohol, and opiates. Those are kind of like the three that I deal with the most. Meth and alcohol probably being primary. So yeah, that's just kind of a location thing. I know it kind of like varies. Opioids gets a lot of the focus right now because it's killing a lot like younger people, right? And the risk of overdose because of fentanyl contamination and stuff is really high. So yeah, I kind of ended up in addiction because my master's program was a dual master's, so I ended up having that background, and we lost a addiction counselor, and they asked me if I wanted to do it. And when I started, because I used to see addiction as a therapist as like a barrier to what I wanted to work with, which is like all these other mental health symptoms, so I kind of avoided it. But once I started working with it, I totally fell in love with it because of its complex sort of like relationship to trauma and the awesome deep communities that sort of exist and people's stories and seeing them, connect with each other. Because the best treatment for addiction is group therapy, right? So I run a group and yeah, it's my favorite thing, right? So I'll always work with that in some capacity too, even though it wasn't the OCD that I went in wanting to work with, the most.
Methamphetamine is not a drug that I've ever encountered. I don't know anyone in the UK that I've spoken to who's ever taken methamphetamine. And it's not like I haven't had exposure to drugs and drug people. It's definitely got more of a prevalence in the USA for some reason. I don't know why that is. It sounds like a very dangerous drug. There was this line that I always said I would never cross, and it was heroin, crack cocaine, and methamphetamine, and I never will. Yeah, I think it really can take over the life of someone, right? Once you've had one go at it, the obsession with getting more of it and hitting it again and again and again and again is so overpowering. What is it about it that's so overpowering from clients
Well,
you've spoken to?
what it is with meth, I mean, it's a little different for everybody, sort of like what grabs them. And I think there is a really interesting conversation about why a person like loves meth and why a lot of people can't stand it, and then why some people kind of prefer the downers. But I mean, it's flooding your brain with just crazy amounts of dopamine, right? So you're enjoying the energy, the euphoria that sort of comes along with it. You can stay up for days. What really leads people more to meth, though, the trajectory that's really common is they start experimenting with stimulants, Adderall, cocaine, things like that. They're taking that for a while, but it's not really, cost effective to continue with, cocaine because it's very expensive. Meth lasts a lot longer, so your money goes a lot farther. So then they sort of like switch over to meth, and that's when they really get in trouble. But yeah, people don't typically start with meth. It's usually some of people who like stimulants. They're experimenting with that stuff, and then it's more of like a cost-effective issue that kind of leads them to methamphetamine. Not in all cases, but in a lot of them.
Does meth not make you hallucinate?
Yes. So
Where does that component come from? Because you don't typically hallucinate from, say, speed or cocaine, as far as I know.
there's a couple things going on. One of them is a lack of sleep deprivation. So meth lasts a lot longer than the other stimulants. So you'll have
How long?
people. So you can be high for like 4 to 9 hours. I mean, it depends on a lot of factors, but people will continue to use several days in a row. So they're getting no sleep. Right. And so sleep deprivation causes those psychotic symptoms a lot of times. And then, with psychosis, we have sort of a dopamine hypothesis, which too much dopamine in the wrong places of your brain creates a lot of those like, positive symptoms like paranoia, agitation, hearing voices, seeing shadows. That's really common with meth. So it's a little bit of both of those things kind of working together, I think. But and for a lot of people who continue to use meth, a lot of those symptoms, even when they quit, don't subside, right? We're kind of dealing with lingering psychosis in the long term, unfortunately. So there's definitely some permanent, damage also happening in the brain. It's a bad in the way that they're manufacturing it now. They ban some of the ingredients and then they switch to new ones, and then that causes all kinds of problems. But on our inpatient unit, we can kind of see when there's a bad batch, because we'll have a big flood of hospitalizations of people using meth with really severe, psychosis and things like that. So there's quite like I said, there's a couple things going on there for sure.
Very sad to hear. Let's relate it to trauma, because that's what we're supposed to be talking
Yeah,
about.
yeah, absolutely.
You think most people who you see who have struggled with, say, meth addiction also have that trauma. Is there a theme running through the traumas that present to you? Is there, I don't know, a correlation between certain abuses that they've suffered that leads them more towards, I don't know, a stimulant as opposed to marijuana or towards an opioid? What's your experience with people suffering with meth addiction?
I haven't noticed in terms of like class of drug, different types of like traumas that tend to be typical. But what I do notice is with meth and heroin, especially as we get into routes of administration like injection and stuff like that. That's where you start to see the traumas being a lot more frequent and severe, right? We get into those, like, I don't love the phrase, but sort of drugs of despair, right, is the way that people put. But a lot of times when we get there, I mean, sexual abuse is sort of the most common, right, theme that I sort of see running through there. And then there's just the psychological and physical violence a lot of kids are exposed to with parents that they themselves are dealing with, addiction, narcissistic abuse, all kinds of other kind of cocktails there of unpleasant things. As far as I'm aware, it's a lot messier than drawing a direct line between this type of trauma and this drug. But frequent traumas, severe traumas tend to lead to, again, those like kind of more severe addictions, right, that have the worst consequences, like methamphetamine and opioids.
It's interesting because I struggled. I had this conversation earlier in a different podcast. When I was 18, when I was 16, I went to a new school and all my new friend group there had been drinking since the age of 14 and 15. It's a bit of a problem in the UK. And I started drinking at 18. And the main reason was because I was so nervous, so socially awkward and worried what people thought of me, afraid of people. So I would drink to get drunk so that I wouldn't feel anxious anymore. And I no longer drink because I recognize that behavior in myself. But something like methamphetamine is an upper, it's a stimulant. And that kind of, I don't know, when you talk about people who have experienced sexual abuse, my assumption would have been that people want to escape from that pain, that trauma. But it's the opposite way of thinking with a stimulant. I'm quite surprised by that.
Yeah. Trauma is really sticky because you kind of see it go to either end of the spectrum, right? So sometimes we'll experience a trauma and we say, I never want to fucking feel that way again. Maybe avoidance, downers, like you were saying, shutting down, totally avoiding. And then we have that other end of the spectrum where there's some traumatic reenactment. There is, kind of being drawn back to those same places and events and, and substances and sort of things, like where, being, sort of awake and wired is, kind of a feature of that disease that sort of works. It's doing something for them, right? That is helpful. So yeah, I mean, like it comes in all kinds of different sort of presentations. Cause I know what I think with trauma, what kind of gets the most attention is sort of the intensity, hypervigilance, panic, some of those like really anxious and sort of keyed up feelings. But a lot of times too, there's like, it's, this hypoactivity, right? Where we're flat, we're depressed and we're numb, right? Where our system's just been hit so much, so hard that, we're shutting down, we're dissociating, we see a lack of that energy. And I think you could, it makes sense to me that sort of based on which presentation you have could dictate which drug you kind of gravitate towards, right? But in terms of like whether or not that's been studied, I'm not familiar with any of it, but it makes sense to me. And that's an interesting question. I actually want to kind of I'll deep dive into that when we're done talking. Yeah,
I would love to record again a second time. I mean, we've got up to about half an hour left, so we'll carry on for a bit. That was just something that I thought off the top of my head. And to tell you the truth, because I'm half asleep, I hadn't made my brain is not working correctly tonight. I haven't made the connection with repeating or enabling yourself to repeat the patterns of behavior that you saw that led to the trauma in the first place. So mine would have been isolation. As a kid, I was afraid of my family, afraid of my mother, so I would hide and I would isolate myself in my room. And obviously that's why I smoked marijuana. Actually, when I think about it now, it's really obvious. It's stupid. I would smoke it at home because it would just make me numb and still, and I'd sit and watch TV. So when you talk about people who have suffered sexual abuse, that stimulant, that fierceness, that awakeness, the horniness that you can get on a stimulant, and yeah, that naturally would lead to putting you back into that same position of vulnerability. Yeah, that could lead to you being abused again or feeling the same feelings of abuse. So I guess that makes total sense when I think about it. Heroin and opioids, couldn't tell you. I mean, it's not something that I've ever dabbled in or ever will, like I said. I'm curious to know if people have struggled with opioid addiction. First one I think of is heroin. I actually don't know how heroin works psychologically in the body or in the moment. Heroin When I think of a heroin addict, I think of someone who's shooting up and then lays back and passes out. But you're supposed to feel very euphoric on heroin. Yet I think of someone who almost numbs and goes into that freeze state. Have I got that wrong? Please educate me. I'd love to learn from you.
Well, so the effects, you're exactly right. It can be sedating, really strong euphoria and body high. But there are people that take opioids that report that they're kind of energized by it. Right? Drugs are weird, If you give me a cup of coffee after noon, I'm going to be awake all night. Some people can drink a pot and go to bed, and you'll hear that people's biologies being a little bit different. But yeah, typically, especially when we get into those like stronger opioids, like you see like the famous like sort of nod. Their posture's really leaned over. They're falling asleep all the time. That's really classic. And that's when you're at that point, it's like the goal is to, one, not get violently ill when you can't access it, but also to just kind of like totally wipe out, right? Kind of obliterate whatever feelings you're kind of moving away from. Usually just trying not to get sick, though, at that point when we've gotten to that level of addiction.
When you say sick, do you mean in the moment like you might overdose, or sick from
sick from like
flus?
Well, I'm saying sick as in a lot of times with opioid addiction, the goal stops being to get high and it starts being get another dose so that I don't get dope sick, right? And like get those flu-like symptoms, horrible body aches, diarrhea, right? And all of those like horrible withdrawal symptoms, right? So that's more of what I mean. But yeah, the addiction does not, when you've been addicted for a long time, the goal stops being to feel good and high, and it starts being, I don't want to feel bad when I don't have access to my drug of choice, right?
I don't know what dope sick means. Can you educate me on that? I know it's not having enough of the certain drug, but what does it mean to be dope sick?
Yeah. So, when you're addicted, the physical dependency from opioids, and one of the reasons it gets such a bad rap is because it happens pretty quickly, right? Faster than other drugs. It could take me years of drinking alcohol before I have withdrawal symptoms when I stop drinking alcohol. Opioids is much faster, right? It can happen in, weeks. So when we get a couple hours out from not having any opiates in our system, we start to feel those physical discontinuation symptoms, which typically looks like a really severe version of the flu. So diarrhea, chills, throwing up, all that stuff. A rule of thumb that was explained to me by a psychiatrist and seems to be true enough. If you want to know what a drug withdrawal is going to look like, it kind of does the opposite of whatever the drug did for you. So in other words, when someone's coming off of methamphetamine, a lot of times you have that hypersomnia, they're sleeping a lot, depressed mood, all of that stuff. And then when you have someone coming off of like, depressants, you have, totally the other end of the spectrum. So yeah, when people say dope sick, the body is no longer in homeostasis where it wants to be when we're in active addiction, which is having that substance in our body, right? And maintaining that. And it's very uncomfortable and miserable. And it drives a lot of really extreme behavior. One of the things with addiction, it all comes down, whether you're addicted to porn or methamphetamine or heroin, it all comes down to like the dopamine systems in our brain. And dopamine, it's the neurotransmitter that tells us to eat, right? I mean, it's hardwired into our brain for survival. So when we are in active addiction and that system gets hijacked, and we are no longer able to take that drug that's giving us that dopamine, you see really extreme behavior because our system's interpreting it as death, essentially, right? Oh, I need to survive. I cannot survive without this. And that's why you see people doing things that they would never do in the absence of those feelings, right? Stealing from family, and all kinds of other, activities that just totally outside of their system of values.
When you're hungover, or when I was hungover when I used to drink, I always used to struggle to eat and to make myself food. And part of that I always used to think was the, feeling depressed and feeling down or embarrassed about the dumb shit you'd done the night before. But also it's because your dopamine system is a bit of a mess. Is that why I wouldn't want to eat? Because I've flooded my brain with dopamine by drinking, and then now I'm not drinking and I I've used up all the dopamine in my brain.
Yeah, I mean, I think that in terms of that system, I'm not sure. I think a lot of times alcohol is such an irritant to our digestive tract that it just makes us nauseous, reduces our appetite. I mean, you kind of see it. You see it at kind of both ends of the spectrum. Some people with alcohol use disorder are malnourished, skinny because they can't eat because of all of that gastrointestinal irritation that's happening. And then some people kind of go to the other end where alcohol has a ton of calories and they're able to eat, and it tends to become a weight issue. In terms of not having enough dopamine suppressing appetite, I'm not really sure. I would have to look into that. I'm not aware of that.
It's a bit unfair of me to put you on the spot like that. I'm just a bit curious. It suddenly popped into my mind.
It's an interesting question, and yeah, no, I'm like scribbling this stuff down because it's stuff that I'm going to want to follow up with, right? I mean, this is what I love about psychology. One of the downside is that it's in its infancy, and one of the things that's really cool about it is it's such an interesting challenge to find reliable information and be rigorous and evidence-based and really kind of embracing that where we can. Yeah, and all of these questions are interesting kind of fuel to kind of keep looking, right?
Well, that's the point of these conversations, I guess, is to at least have the conversations. I've been asking friends to come on the podcast and have these conversations with me, and they're so petrified of putting their feelings out there and their emotions and being vulnerable. But it's very important that we are. That's what I love about the group setting of your addiction patients. I was always very reluctant to touch AA or NA for my struggles. I was very acutely aware that my problems were inside me and that I was hiding, and I knew what my problems were, but I didn't know how to step away from them. Fortunately, I found my own way, and I've not ended up needing that group setting. But I think for most people to know that they're not alone, that it's not just them, that there are other people struggling as well, is a big thing that we need to break through. That there are 8 billion people in the world. You are not the only one struggling with a meth addiction or problem with alcohol or marijuana. I've got a few friends who I know are struggling with those things, but I don't know, aren't ready to make the changes that I'm making. Again, earlier I had that conversation with someone else on the podcast about moving away from your friendship groups that used to revolve around alcohol. I've got quite a few guy mates who we'd go to the pub or the bar and drink some beers and watch the football together. But really, apart from that and getting drunk and doing dumb stuff and chasing girls, we really didn't have a lot in common. And yeah, those friendships no longer served me. You've got to find that right community, I think. Sorry, I'm rambling a little bit here.
No, and I'm glad that you kind of framed it that way. Yeah, because I run groups and they are not AA or NA affiliated in any way. I think those communities can be great, but they're not for everybody. And what you say is so important, that you need some type of pro-social engagement, right? You need a community. I think AA and NA creates a really easy pipeline for people struggling with addiction that can kind of get into that. And for some people, that's really good. But you can find that in other places, right? But you have to be looking, right? That's kind of the work part that we sort of put in. Staying addicted is a full-time job, right? Whether you're seeking the substance you want, recovering from using the substance you want, or being intoxicated on the substance you want, you have all of this time that is being eaten up. And then when you get sober, you have excesses of time and you're like, okay, well, what do I do with that time? And if you sit around staring at a wall, you're going to relapse, right? And so you need to find a way to find that meaning in your life and get energized, right? Do more of what your values are kind of telling you to do.
And also understand why you're struggling, because there's a reason that you're suddenly in this position where you can't put down the drink, or you're chasing that next high when other people aren't. And yeah, understanding where you've come from is a big part of that puzzle. And again, that's why it's important to have these conversations, I think.
Yeah, absolutely. I'm so glad you're having these, sort of open discussions and I think that goes a long way with destigmatizing, mental health. One part, and I know we talked about this in our initial meeting, that it's a double-edged sword, but I think it's a net positive. But like all of these mental health topics really have entered the mainstream. And so, we hear it in the language of the TikTokers, and, every week I have someone who has self-diagnosed, whatever, mental health issue is in. And I think it's great because it connects people with services, right? And it gets people kind of curious about themselves and what they're struggling with. And that outreach is so important. But then having conversations like this too, where I think it does it pushes it forward without quite the pop psych, a flavor that maybe we see on the other outlets.
Well, thank you. Look, it gives me encouragement to keep moving forward. I just had a question pop into my head. I'm curious to ask you, when you have your groups of people in recovery or who are struggling with addiction, is there not that danger that you're suddenly putting a load of addicts together in a room and then they start talking about how great this certain drug is and, oh, this was amazing when I did this, or do you remember this high? And is there not a chance that you re-energize the addict in them who then starts to go searching for something? I assume that it must be some sort of requirement that you're sober to come to these meetings, or at least sober in and around them, right? Sorry,
Yeah,
two-part question. Do they not re-trigger themselves? And surely they must be sober to be able to attend.
Yeah, so the way that people are typically connected to my group is they come off of the inpatient unit after a detox, and then we just kind of, hey, I go over there and I meet them while they're in the hospital, tell them what I'm about, and try to get them over here. We do, if conversations like that start coming up, we shut that down, because one of the things that our addiction tries to get us to do is separate the consequences from the high of the drug. And what I really try to make sure that we do is be really honest with ourselves about what that drug is doing. So if you are in an intensive outpatient program, 9 hours a week, you probably came off of an inpatient hospitalization for in one way or another, your life was in danger, right? Whether it's literally, right, danger, overdose, or whether it's, your relationships or your career were in danger. But either way, it had taken over. So if we hear that and we have a really good, group and cohesion and culture that they kind of have lead here, people bring it up and they're like, hey, well, yeah, I mean, there were things that we liked about it, and we want to stay curious about that because that can give us some direction in terms of what we want more of in our lives while we're sober. But we do want to be really careful not to just romanticize that and lie to ourselves about what it did too, if that makes sense. But it is a risk, right? The last thing you want is people coming in who are, don't really want to be there, and they're like, oh, I wish I was high, and then they link up, meet in the parking lot, and you never see them again.
Does that happen?
No. Well, so I get to run my own program. I screen everybody before they come in. And even when they're court ordered, I make sure that they want to be there, right? And you're right. So they do need some level of sobriety. So we get drug screens to make sure that they're not actively using. If someone fails a drug screen, I don't kick them out of group, but I will, we're like, okay, well, what are we going to do differently, right? And some of the best conversations that we actually have had in group is when someone has a slip and they come in and they're like, hey, here's what happened. And we sort of do a post-mortem with the group, or, like, why did this happen and what can we do in the future to make sure it doesn't happen again, if that's our goal. And so hopefully we can kind of use all of those things for sort of rich territory to, learn about ourselves and what we want.
It's difficult though, because you can't encourage relapses knowing that someone can just come back again and again and again and again. I use the example of a dog that bites you, a pet dog. If dog bites you and then the dog bites you again and again and again and again and again, at some point, unfortunately, if the dog isn't going to learn, you have to get rid of the dog. But if you have, I don't know, an individual who keeps relapsing and then keeps relapsing, at some point, what do you do for them? Because obviously you want to help them, but you can't allow this sort of behavior. It must be a very difficult situation. Has that happened to you?
Yeah, absolutely. I mean, look, I'll continue to work with people. If the question is, what am I going to do differently next time? When that answer starts being nothing, and we're just going to keep sort of walking into that trap, I won't keep them in group, because, you just can't have someone who's consistently actively using in group who isn't really interested in sobriety at the moment. But
not only that, but they'll let other people down and I don't know, for the other addicts in the room or the other people in recovery, they can be dragged down by someone else falling down. So you need to isolate them, right?
Yeah. So then we'll kind of go to individual therapy, and maybe we take a more harm reduction approach, right? Like, hey, I'm not ready to be sober right now, so let's make sure that we get to live with as much dignity as we can, right, while we're in active addiction. And then when they do become ready later, right, be ready to sort of jump in and keep them on that fold. I'm a huge believer in harm reduction. I think if our goal is to keep people alive and get them connected to treatment, it's the best way to do it. So we'll just change our goals. I'm not here to convince anyone to get sober. I'm not interested in that. If someone's actively using and that's not a part of their treatment plan, that's their deal, right? Like keep, it's working for you, whatever. But when they're ready and they want to stop and hey, we're here. We kind of know how to do that, right? And we do it pretty reliably. We have pretty good outcomes.
You sound like you've got very good energy. You sound, like I said this funny enough to another guest. It's like a very good human being who's well positioned to be in this field. I think you found your calling, and I'm really glad that your patients and the people in your area in Indiana do have someone like you to talk to. I'm grateful that there are someone like you out there to help people, man. Good for you.
I appreciate you saying that. And I think, I started this talking about, sort of the misery of living with OCD. And truly, if someone said, hey, I'll give you $1 million to go back and live like that for another year, I wouldn't do it. I was so miserable. But if there's one thing I can kind of reflect on and be grateful for, is that in a sort of a roundabout way, it got me connected with this career that I love. I mean, if I'm not working, I'm listening, I'm reading a book or writing my blog or trying to get my business moving. I love this stuff. And having these conversations, right? I love to do it, and I'll come back, and we'll never run out of mental health topics to talk about, right? So yeah, a lot of gratitude to get to do this work too.
I forgot to ask you about your blog. Where can we find your blog?
Yeah, so bantacounseling.com. That's my website. Right now I'm putting together, it's the Trauma Therapy Survival Guide. So it's totally free. The goal is to augment therapy, right? So here's the things that I would want myself or my clients to be doing outside of the therapeutic space to manage these symptoms. It can even be good to, if therapy is not something we're ready or want to do, it's stuff that can really help manage some of these intrusive trauma symptoms. But it focuses, the first level, sort of the psychoeducation. We're going to understand trauma, right, to demystify it. And then, the second step is like a variety of different evidence-based techniques that reduce some of those intrusive symptoms. If I have an example, because I do have kind of a favorite example, if we have a little bit of time.
Please. You've been a great guest to talk to. I feel like I've not been on the best form, but you're more than welcome to come back and do this again. But hit me.
No, hey, I appreciate it. A piece of research that I'm kind of obsessed with right now that I thought is so cool. So what they did was they took people in an emergency room that had been in car accidents, right? And they gave them Tetris to play for 10 minutes right after the trauma. And then they had a control group where obviously they didn't, they didn't look at all, or they didn't have anything that they had them do. So what they found was 62% of the people who played Tetris for 10 minutes within 6 hours of that car crash, they had 62% fewer of the intrusive symptoms. So that includes the insomnia, depression, panic that kind of comes up as a result. And then they took this Tetris idea and they were like, let's expand on this. And they gave it to combat veterans that they had PTSD diagnoses. When you take someone with PTSD and you scan their brain, they tend to have a hippocampus atrophy, right? So their hippocampus is about 6% smaller than what the average one would look like. That's our memory center of the brain. So that's kind of like the thumb drive in our head. And they had these combat veterans that had these atrophied, hippocampus, and they had them play Tetris for, 30 minutes a day, right? I think it was. And then a month later, they scanned their brains again, and they realized some of that volume had, increased. And not only that, even in the group that was also doing trauma therapy concurrently, the people who played Tetris had even better sort of re-inflating of the hippocampus. And then they took this data and they were like, okay, PTSD is a huge problem in the healthcare system right now. And, during the COVID pandemic, all of these nurses in the ICU floors, they were just seeing people die constantly. And they had one group of nurses play Tetris at the end of their shifts, and they had one group not play Tetris, right? And that's it. I mean, it's totally free, this free thing. And in the group that played Tetris at the end of their shifts had a tenth of the trauma reactions that the group who did not, right? So the point of this guide is to sort of take things like that people aren't really aware of and say, hey, look, there are things that we can do outside of here that can be almost a mental hygiene. So some of the stuff like the Tetris thing is probably lesser known. People haven't really been exposed to it. Some of it's a little bit more meat and potatoes, like ways that we can like sort of ground and maximize results. But my goal with this is to, one, it's going to be completely free and everything in the guide is going to be free. So I'm going to make sure that anything that someone reads on there, they're going to have access to, and then they're going to understand why it works too, right? So we're going to kind of break down, here's what the research says. If someone's really interested in that, they can read it, but they don't have to, because I think it's important to kind of show our work. But that's the point, or that's what I really want to get across with this guide, is education and access.
It was, Banter? What was the
website? BANTA and then counseling.com. Yep. So there's a blogs tab that's going to be all my free, content. I write right now about like a bunch of stuff. There's going to be some stuff on mental health and addiction policy. There's going to be stuff on like, the classic trauma, EMDR, which is how I like to treat trauma, information about that. And then in a couple weeks, we'll have that trauma therapy survival guide up. I've really been loving writing it. And I want to get in front of as many people as possible. And I hope they get stuff out of it. But I love this stuff. I love talking about this stuff. So I'm happy to do it anytime.
Dude, and like I said, I think you're a very good person to have out there in the community helping people. I'm grateful you're out there. I've got a whole host of other questions that I could ask you. I'd love to have you back another time, but I see we're running out of time. EMDR is something that I've been looking at for myself. So, I mean, I'm sure that I could dive in and ask you 1,000 questions on that. Thank you very much for coming on. I really, really appreciate it. I've learned something today, at the very least, about using Tetris in trauma. I pulled up the paper as you were talking, and I had a quick glance of it. I'm going to put it in the description of the video if anyone wants to have a look at it, as well as your blog. Fortunately, with episodes like this, as the channel grows, they won't be seen by thousands and thousands of people straight away. But as it grows, people will keep coming back to these episodes, and I hope they're driven to your website, because you seem like an awesome dude. And I'd love to have you back another time. Thank you very much. I really appreciate you coming on.